Hi friends, in today's video, I'm going to be speaking about thymosin alpha and recurrent pregnancy loss. Remember, thymosin alpha is currently not a labeled drug for recurrent pregnancy loss, but it is a broad immune modulator. Actually, when we were all small children, the thymus gland, which is present behind the sternum, it produces this drug called thymosin, which is an immune modulator. It increases the regulatory balance of the T cells, which are very important in maintaining immunity. And this is something which we use in patients who are having recurrent pregnancy losses, because we believe that when regulatory balance is good, in that type of situation, the T helper 2 ratio, we actually want TH2, that is helper cells 2, to be more than helper cells 1. And when we want that, we probably think that thymosin is going to work, and it actually works because it increases the regulation very nicely. Now, with all this in mind, we need to understand that when a patient has recurrent pregnancy loss, NK cell activity is very high, there is a pro-inflammatory state in the body, and the uterine implantation gets severely affected in these situations. But remember, friends, before you prescribe thymosin alpha to any of your patient at any given point in time, you should make sure that the embryo is chromosomally normal. Pelvis is absolutely normal. Pelvis is free of everything else. Embryo is genetically tested, and all other causes of immune dysregulation, like let's say rheumatoid arthritis or ankylosing spondylitis or anti-TPO antibodies or ANA titers or APLA or whatever you can think of, is negative. It has to be ruled out. It should be an idiopathic cause for having recurrent pregnancy losses, right? So thymosin, when you administer to the patient, the standard drug is available as 1.6 grams. In this situation, before we actually administer, we would want to make sure that the NK cell ratio, which is present, okay, is actually more than 12%. We do a blood test to look at the peripheral NK cells. It is commonly available. And if it is more than 12, you can consider to use thymosin alpha in those patients. As I said, before you give the molecule to the patient, T regulatory cell levels, rule out everything else, as I have mentioned, karyotyping, genetic testing of the embryo. And in that situation, we normally recommend the patient to try thymosin alpha, 1.6 mg, at least twice to thrice in a week for a minimum window of around 3 weeks. When you do this for approximately 3 weeks, then you start planning for conception, and you continue it during the phase of your conception for the next 8 to 12 weeks, and then you can conceive. The same thing we do for embryo transfers. Even when we are doing embryo transfers, we want the patient to start this actually 3 to 4 weeks before the embryo transfer. Okay, and then it continues till approximately 9 to 12 weeks of gestation. This 9 to 12 weeks of gestation is currently arbitrary. We do not know the actual mechanism of 9 to 12 weeks, but we believe that placentation is complete at 9 weeks, 10 weeks, and that is why majority of the people give it till the end of the first trimester. What have clinical studies shown? Remember, the data is very less, but whatever little data is available has shown that there is a benefit which occurs if the patient selection is good. What normally people would do is, in India, what people would normally do is they'll give LIT also, they will give intralipid also, they'll give IVIG, thymosin, they'll give everything. So we don't know what actually works. But when you have chosen the patients very nicely, this is something which works in IVF as well as in non-IVF patients who have had recurrent abortions. And that is why this molecule should be used judiciously and nicely.